Dr. Basim, how are you?
Hi, Dr. Yasser, welcome.
When are we going to start?
We are waiting to
Hello,
start.
Dr. Basim. I'm Abdelaziz. You can start if you are ready, Dr. Basim.
Okay.
Okay.
Are we on?
Yeah, I am.
Yes, I'm also ready.
Okay. Good evening and welcome to the first webinar of the Egyptian Shoulder Surgery Association. The founding members of the 2-month-old society made a tremendous work of building the society and making this webinar a reality. We are also very happy to have many international experts in the field of shoulder surgery. Dr. Valenti, Dr. Panopoulos from Greece, Dr. Verbocht from Belgium, and Dr. Ansara from UK, and Dr. Nikolai from Germany. Also, we want to thank the company Eva Pharma for their great support. The webinar about the fractures of the shoulder will start at 8 p.m. Till then, Dr. Nikolai from Germany will talk about shoulder rehabilitation updates. So please, Dr. Nikolai.
Okay, so I will start. First, I will introduce myself. I'm Dr. Nikolai. I'm working since around 20 years with Dr. Basim Pfleger. And I have a lot of experience with a lot of patients for shoulder therapy. And I have to close the camera now and I will open the presentation, okay? 1 second. I hope it works now. I think now it's working. No, it should. Okay. Okay. So, can you hear me?
Yeah.
Okay, fantastic. So, we start with first with the rehabilitation of the shoulder. And the main problem is that we have complex issue because the shoulder is completely with soft tissue in the hanging joint. And so it has to be treated very carefully. So very important is the rehabilitation. So you have to do the rehabilitation in the small doses. You have to do it several times during the day. And especially you have to do it alone as a patient in a home treatment. It has to be around 10 minutes for each training, and the training should be around 3 to 5 times a day. So it should be like a team between the physiotherapist and also the patient and the doctor. And you have to do it every day, and you have to monitoring the physiotherapist.
What's up?
The physiotherapist needs to control the patient and she should motivate it. And always he has to do every 2 weeks to make a report to the orthopedic surgeon. And the surgeon should see the patient every 2 weeks. And then he should say to the patient everything is working in the right way, and the physiotherapist sees the progress and make necessary modifications in the according to the operation. Okay, go to the next. So now the next very important thing is the measurements of the motion. Measurement of the passive and active range, as well also for the strength, are the tools for the monitoring in the progress. You as a physiotherapist makes the documentation. If something not working, you make a readjustment, and the consultation with the orthopedic surgeon. And especially you have to do always control and motivate the patient if you do the exercise right. So for this, we have a 3 phases physiotherapy program. Okay, there's phase number 1. Phase number 1 is self-assisted exercises with isometric exercises. Then we have 3 main start exercises in this. These are the top exercises. It's very important to do this because this is basic. This is very important to make the shoulder move, and it's the pendulum, the passive external rotation with the stick, and the passive elevation. And for this, we're using a pulley. And this pulley you can do on the door, and you can use it everywhere you are. This means if you use this 3 exercise, you have always sure that there is no stiffness in the shoulder. And these are like the most important exercise for the shoulder. You have this, and these are like to do it 5 times a day for 5 minutes. And if you do this, this is fantastic. You have to control it as a physiotherapist, and then it's working very well. Okay, so the next, it's internal rotation. It's isometric exercise. And you start it after 10 days. And for this, you can to remove the stiffness, and you can train the muscles and the tendons for this. It's very important. And now we go to the next exercise. This is also a picture for a lot of exercise. It's together with the pendulum. You can see the pulley exercise. And these are isometric exercises. And these always starting after day number 10. Okay. So the phase number 2, it's now self-assistant exercises for activating and stretching the muscles. Here we have some examples. So you can see here with the help of a stick and a soft rubber. In phase number 2, we activated and started to train the muscles. Normally we do this after 6 weeks post-operated. So you have to do it also very carefully, not to make it too strong at the beginning, and then you have to make it more and more a little bit stronger. And you have to control the passive range of the motion. So if this improved, you can start with stretching exercises, external rotation, internal rotations, and also the concentration on the weak points of the patients. So next flips. It's phase number 3 now. So in vigorous, we are stretching and strengthening also the exercise to regain the full range of motion. And we strengthen the elevation especially and the external rotation to have it in both sides similar, that we have left side and right side in the same style. These are the exercises also from phase number 3.
Is all pictures shown on the screen? You can block it.
So now standard. So now we have some standard measurements. And besides the monitoring, the active and the passive range of motions, we also monitoring, and the strength of the elevation. External rotation is also very simple and easy. You can do it, you can see it in the picture. We measure it like this. It's very easy to see how is it working, the elevation, the power of elevation, and also of external rotation. Okay, and now phase number 3. For athletes, we have some special programs, so you can make the measurements in a daily report, and so you can see actually how you have the progress from the elevation, and then you can control it on the left side and also on the right side, and then you can see how is it working and is everything coming in a good way with the patient. And now we have also some special targets. So we have the targets that the activity on both sides should be normal. This means left side and right side should be from the movement completely normal, and also the power and the strength should be standardly on both sides the same. Okay. Now we have the patient. This is him. So you need to, before you start with the operation, you have to tell him 4 months post-operative rehabilitation that he needs 5 times a day this treatment for 5 minutes. And it should be done only by the physiotherapist to 5%. This is homework, and the main work should be done by the patient at home, because you can't go to the patient every day. You have to teach him when he's coming to your clinic what is exercise. You have to measure it, and then he needs around 5% only with the physiotherapist. And so you have to reduce the cost for the treatment. And so you have a lot of work done by the patient, but you have to control it very, very, very strong, and also every week, because if you do something wrong, you have to make some invitation. Okay, so the main pathology of the shoulder. The main pathology of the shoulder are impingement syndrome, rotator cuff tear, instability, fracture, proximal humerus, fracture from the glenoid, the AC joint dislocation, and also the glenohumeral and AC joint osteoarthritis. So now you see how NIR is treating. NIR describes the different stages of the impingement syndrome. Stage 1 is reversible, edema and hemorrhage. Stage number 2 is fibrosis and tendinitis. Stage number 2 is fibrosis and tendinitis 2. So stage 1, you have a local treatment of the pain, 4 to 5 days, no manual therapy. Then you start gentle and passive self-assisted exercise like we offer this in phase number 1. In stage 2 from the impingement, tendinitis and fibrosis, we working with heat, ultrasound, manual inferior glenoid humeral stretching, isometric self-assisted stabilization exercises. After 6 months of failed physiotherapy, consider surgical intervention of arthroscopic subacromial decompression. So now you can see how is it before and then after the decompression. So the partial and complete rotator cuff tear. So for the first 6 weeks, wait, now I have it to make it more on this plate. So for the first 6 weeks to 12 week, we start with phase 2. So activate and assisted exercise and stretching exercise. And we are monitoring the progress of the active and passive motion. Assisted with physiotherapy and manual therapy twice a week. And for this, we don't need any heavy exercise because otherwise we get problems if we make heavy exercise with the muscles and with the tendons. So we have now the rotator cuff tear surgery, small to middle size tear for the first 6 weeks. Wait, I have to switch on the lights. So we start with the phase number 3, stretching and strengthening with self-assisted exercise. This means also 5 times a day, not more than 5 to 10 minutes. It's very important. Local physiotherapy we do twice a day. The measurements and the strength and monitoring of both sides is also very important. So rotator cuff tear surgery, small and middle size. It takes around 6 to 12 weeks. And we start with phase number 2, monitoring the progress and active and passive motions. Again, so once again, rotator cuff for small to middle size, we have it here, and now we come to the instability. So here you can see the case, it's a Bankart lesion. In case of a Bankart, we repair with a normal capsular operation. And then we start with physiotherapy. We usually start with phase number 1, passive self-assisted exercise after 2 weeks. And then we make a local physiotherapy. And we start the next phase after 4 weeks. And then after 8 weeks, we start with the phase number 3. So, and for the open inferior, what is this? Open inferior capsular shift. In case of this, we start with phase number 1. And then we have the arthroscopic inferior capsular shift again here, how we did the operation. Now we can see how we make the fixation of the patient. The fixation is working with a special gips. You can see it here on these pictures. The patient is usually for around 3 to 6 weeks inside the gips. Okay, and then we have also inferior capsular shifting surgery. We start phase 1 after 6 weeks for 1 week, and then we asked phase number 2 1 week later, and phase number 3 after 1 week later. Okay, so now we have fractures. When you have an open fracture and you have to, it's very hard to wear an intentional fixation. So we start phase number 1 after around 2 weeks. Okay. Total reverse the shoulder. You can see it's a total reverse, and now you make an anatomical total shoulder. We start with phase number 1 after 6 weeks, and you can't do this rotation for 6 weeks. Phase number 2 and 3 after 6 weeks. So the fracture of the transverse fixations, immobilization for 3 weeks, phase 1 after 3 weeks, phase 2 after 4 weeks, and then we start phase number 3 after 8 weeks. And so now, very important, you have to know the exact pathology of the case. When you are the physiotherapist, you have to speak to the orthopedic surgeon about the surgery, adapt the program inside the clinic work, treat the patient and control his homework is very important. Inform the surgeon if you have the progress, and if there is some problem, you should talk to them also. Okay, thank you. And greetings from Cologne. I hope you can hear me well. If there are any questions, you can talk to me. Okay.
Thank you very much, Dr. Nikolai. Appreciate your quick preparation and presentation. I just want to make a small announcement that the society is organizing training courses and training fellowships for short time and long time, and this will start next year. And also we have on our site publication assist, which
I'm sorry, Dr. May you please unmute?
Pardon? Hello?
Someone was talking.
Can I talk?
Yes, I think so.
Okay, thank you. So we are giving service to all the members of the society to have a publication assist in our society for free. They can present it for our website, EGSSSA.net. Now I have the pleasure to present my friend, Dr. Yasser Asafuri, to start the webinar about the fractures of the proximal humerus. Please, Dr. Yasser.
Okay, do you hear me?
Yeah, go on.
I'm not connected.
You connected. We can hear you very well. In Germany, connection is working.
Okay, now I'm connected. First of all, I want to welcome the guest speakers for this first webinar of the EGSSSA. We want to welcome Dr. Philippe Valenti from France. He's the president of the Paris International Shoulder Course. We want to welcome Dr. Andrea Papagopoulos, the president of the EGSSSA Life Surgery Course and the Secretary General of the Hellenic Arthroscopic Association. Also, it's our pleasure to welcome Dr. Oliver Verboch, the president of the Belgium Association of Orthopedic Surgery and Traumatology. Also, Dr. Samah Andras, Dr. Samah
Ansara, not to worry. My wife cannot pronounce it up till now.
Ansara.
25 years and she struggles.
Very sorry, Dr. Samah Ansara from UK. And we want to thank Dr. Nikolai for his very nice presentation. So now I'm going to present our first talk about fractures and open reduction or internal fixation of the proximal humerus. If you want to allow me, please. Okay. When do we do open reduction and internal fixation? First of all, this type of fracture is common on osteoporotic bones in old age, so it's called osteoporotic fracture, but in young individuals, it's usually a high energy. These fractures are common in females more than males. Fortunately enough, these fractures, most of them are treated conservatively and they are undisplaced. Basic anatomy, we should know there is the head, greater tuberosity, lesser tuberosity, and the shaft. Also here is the anatomical neck and the surgical neck. There is a certain angle, which is the head shaft angle, which is about 130 degrees. Also, there's a retroversion of the head from 18 to 40 degrees. This should be considered during your fixation because this is basic anatomy. There are certain shoulder muscles which control the movement of the shoulder. These muscles later on create a deforming force in fractures. So if you have a fracture of the lesser tuberosity, it's pulled by subscapularis to the inside, medially. If there's a fracture of the greater tuberosity, there's a pull posterior and superiorly by the rotator cuff, and the shaft is pulled to the inside medially by the pectoralis. The blood supply of the head is important. You should know it's coming from the axillary artery through the anterior and posterior circumflex humeral arteries. The anterior circumflex gives the ascending branch and the arcuate vessels which supply the head. You should take care here that these vessels enter the head and pass through the quadrangular space very close to the medial hinge or the medial cortex. Most of us use the Neer classification, but the AO classification is also important, especially in documentation. So we have type A, which is extra-articular fracture, unifocal. Type B, extra-articular bifocal. Type C is articular fractures. We're going to concentrate on the near classification. It depends upon the parts. So we have fracture at the anatomical neck, 2 parts, at the surgical neck, greater tuberosity, lesser tuberosity. Or we have 3-part fractures, the head, the greater tuberosity, and the shaft. Or 4-part fractures, where there's a greater tuberosity, lesser tuberosity, the head, and the shaft. Any of these fractures can be fracture dislocation. You stated that a fracture or a part is the part which is displaced more than 1 centimeter or angulated more than 45 degrees. But there are certain points to remember here. Some surgeons consider that the greater tuberosity is a part if it is displaced 5 millimeters, because they consider that this amount of displacement may cause impingement. Also, you should know that 2-part greater tuberosity fractures may be a part of a terrible triad, where there's a fracture of greater tuberosity, anterior dislocation, and axillary nerve injuries. These fractures have very bad prognosis. The lesser tuberosity and the anatomical neck fractures, in cases of posterior fracture dislocation, can happen and they can be missed. In cases of impact fractures in valgus, these are considered innocent fractures and they can be treated conservatively. But in cases of impact varus fractures, or in conditions in which there is over valgus, or there is an angle 180 degrees, these give bad prognosis and should be managed in another way than conservative treatment. How can you predict the vascularity of the head? And if there's a high possibility of vascular necrosis, most of us considered the criteria of Hertel, who mentioned that there's a higher incidence of avascular necrosis if there is a metaphyseal part attached to the head less than 8 millimeters, or if the medial hinge is disrupted, or if there is a fracture through the anatomical neck. So if you have a case with a head fracture and a large piece of metaphyseal bone, this gives good prognosis and you can go for internal fixation. Or if you have a fracture with impact medial cortex, in which there's continuity of the medial cortex, this will give a better prognosis. The radiological workup, the classic, is to do an AP view, do a lateral or scapular view, and do an axillary view, which is difficult in trauma cases. That's why we can use a CT scan. These X-rays are done in an erect position, either standing or sitting. So this is a classic AP view where there's no overlap between the head and the glenoid. The lateral view, the axillary view, which is difficult in trauma patients, but you can do this type of view, which is the apical view, and gives the same information as the axillary view. Is there a role for MRI? It's not widely used in trauma cases and proximal humerus fractures, except if you want to assist the rotator cuff, especially in pre-existing conditions of rotator cuff pathology or in cases of revision surgery. What are the indications? As we said, according to near classification, if there is a displacement more than 1 centimeters, or if there is an angulation more than 45 degrees, especially in multi-trauma patients. But sometimes it's not suitable to reconstruct subtypes of fractures, especially in low demand patients or in severe osteoporosis, or if there's a high risk of avascular necrosis. In this condition, it's not suitable to do open reduction, identification, and fixation, and there should be other techniques to treat this patient by, like arthroplasty. There are different techniques of internal fixation. One of them is the plates, lock plates, but there are other types of fixation like K-wires, percutaneous, or intermedullary fixation, which are not mentioned in this type of presentation. If you see fractures like this, which are impact with a good head shaft angle, then you can treat them conservatively. But if you have cases like this, fractures with displaced, fracture dislocations, or greatly displaced greater tuberosity, then you consider open reduction internal fixation. Plates, which give very good stability and are designed to be lock plates, are very suitable for fractures of the proximal humerus, but the technique is very demanding, and you should know the tips and tricks when using these types of fixation, which I'll mention in the coming presentation. First of all, you should correct the head shaft angle, restore the medial cortex. The screws should be hitting the medial cortex and distributed so that they have a firm grip on the head. It should not be high to cause impingement. Should be a space between the tip of the head and the tip of the plate. What approaches to use? The deltopectoral approach is very common and used where they go between the pectoralis and the deltoid, identifying the cephalic vein, and they can reach the fracture, and they can even extend the fracture. The approach reach shaft fractures through this approach. It's a very comfortable approach for the surgeons. Most of us use it. But there's also the deltoid splitting approach, especially in cases of greater tuberosity fractures, where you go between the anterior and the middle fibers of the deltoid. But in cases where you want to extend the approach, you should identify the axillary nerve, which is about 6 to 7 centimeters from the tip of the acromion. What are the tips and tricks? In your decision making, you should select your patients, and in cases like this, where there's disruption of the medial cortex and high possibility of vascular necrosis during doing internal reduction, open reduction, internal fixation, you should know there's a high incidence of a vascular necrosis and should mention it to the patient. But in conditions like this, where there's a big metaphyseal part attached to the head, although the fracture looks complex, this gives a better prognosis. You should not leave the head inverse. You should always correct the head shaft angle. Otherwise, there is collapse and you lose your fixation. What to do to reduce the head? First of all, you can pass sutures around the rotator cuff, ethibond, to pull the rotator cuff down. Put KOS as joystick for the head. Pass an impactor or a bone lever and push the head, and your assistant abducts the upper limb. You should always insist to correct the head shaft angle and restore the medial cortex. You should always take an X-ray in a auxiliary view to reduce the head and put it in radial reversion. Otherwise, there will be collapse and you will lose your fixation. Sometimes there is osteoporosis or severe comminution of the medial cortex. In these cases, some surgeons consider putting an allograft, fibular allograft, to enhance the fixation and prevent the collapse of the medial cortex. But what about these fractures where there's severe osteoporosis, fracture dislocations, or splitting of the head? Can you do open reduction internal fixation in these cases? I don't think so. And this will be covered in the following presentations. Thank you very much. So the next presentation, do you hear me?
Yes, of course.
Okay. The next presentation will be Dr.
Panagopoulos.
Andreas Papanopoulos. He will be talking about open reduction, transosseous suture fixation, and proximal humerus fractures. Please, Dr. Andreas.
Okay. Okay, of course, I want to thank you for this kind invitation. It's a pleasure, and it's an honor for me to present this technique. So here is Patras, not very far from Cairo. In this area we call Peloponnese, and there's a big bridge. Maybe it's the longest bridge, cable bridge in Europe. This is the hospital, and this is my house, so I can have a good view of the bridge. So, and this is Professor Dimakopoulos. Now it's emeritus professor. He has retired, and he had invented the technique and applied for many years. Now I continue his job. So we have a lot of options to fix these fractures: pins, plates, replacement, nailing. But the key factors are these: the fracture type, the quality of the bone, the integrity of the medial calcar, the comminution of the tuberosities, the risk of vascular necrosis, the age of the patient, and the functional demands. And when I see publications like that, it's a very good publication, a randomized clinical trial 5 years ago that actually said that we have not to operate any kind of fracture in the shoulder because the results are the same. But you compare different things. A surgical group that contains all the types of surgical treatment and conservative. And if you see inside the article, you see that only 4% of the patients had a bad fracture. So you have to be a little bit skeptical about this type of publication because as a shoulder surgeon, I cannot accept a conservative treatment like that. Okay, this is not acceptable, especially in mid-age patients. Of course, we have so many kinds of fixations. This is inappropriate, of course, but we have problems also with the minimal fixation, as you can see here, infection, loosening, bad reduction. So our technique is simple, reproducible, and we use only sutures to bring the tuberosities back together. So the indications for our technique is the 2-part great tuberosity fracture, the 3-part fracture, and the valgus impacted type of 4-part fracture. It's not indicated for complex fractures, surgical neck fractures, because it's very difficult to control the big fragment of the head with a small fragment of the diaphysis, has a small diameter, and also in head splitting or anatomical neck fractures. So it's based in the anatomical classification of Gottman that the fracture lines goes to the old epiphyseal plate and also to the functional classification of Neer. So we don't reduce the graded tuberosity, but the part, the tendon, the subscapularis tendon back to its place. And the same with the graded tuberosity with infraspinatus and epiphyseal. So it's a functional classification, and we have to understand that we try to make a stable constraint. Now, these are the criteria of Herter. We heard about that. So this is not a good indication to have a very small metaphyseal extension of the head. This is an anatomical neck fracture, and it's not good to fix it like that. This is a 4-part valgus impacted with a good medial hinge. So if you elevate a little bit the head, you have space to put the tuberosities underneath. And of course, a splitting head fracture is not a good indication. This is the vascular supply. We heard about that, the posteromedial hinge. That is very important. And we have also conducted a study a couple of years ago in our department, and we did digital angiography preoperatively and postoperatively after 8 weeks. And we fixed these fractures with transocean suturing, and we found that the blood supply is not disrupted. This is the preoperatively image of the small vessels inside the cancellous bone, and this is the postoperatively. So statistically, there was no difference. This is the last publication of our department regarding this type of fracture in 50 patients with a good result. We had only one case of non-union, but you can see here that this is an anatomical neck fracture, and the head here looks like a cell of an egg, and this is the result after 1 year. So we revised this lady with a reverse arthroplasty. Of course, this technique is not old. There are other authors that used different type of fixation with wires, with sutures, with Dacron tapes, with Vicryl, but we think that we have a very good sequence of suturing to make a stable constraint. So this is an example. This is a typical 4-part valgus impacted fracture. Here is the lesser tuberosity, the greater, and the head that goes up to 90 degrees down. It's a very good medial hitch here, so this is a perfect indication for this type of fixation. And of course, many of you consider this fracture as a good option for conservative treatment, but sometimes the results are not good. As you can see here, in this lady, 49 years old, there's a malunion of the graded tuberosity and also a partial avascular necrosis of the head. So this is not a good outcome after conservative treatment. So we use the deltoid splitting approach for this type of fractures. And then after the recognition of the pattern, here is a 4-part valgus impacted fracture. This is the greater tuberosity, and the lesser tuberosity here, the diaphysis in the head. So you see here that there is no one part. It's a lot of pieces, but we treat the functional unit of the lesser tuberosity to the subscapularis. So we pass the sutures here, as you can see, and there is a special sequence of suturing, and this is quite important. So we do holes in the lesser tuberosity, in the upper and lower part, in the great tuberosity as well. 2 holes in either side of the diaphysis in the bicipital groove, and also 2 holes to the metaphysical part of the head. And this is the sequence of the suturing. So we'll have at least 2 sutures that goes from one tuberosity to the other. Then we have sutures that goes from the metaphysical part to the diaphysis, one here. And then sutures that are going from the tuberosities, the upper part to the other side, and the lower part to the same side, in both sides. And this is the final construct. You can see here the holes in the diaphysis. So this is the final construct after the suturing, the knotting. The same technique is applied for the 3-part fracture. And of course, you have the head with the lesser tuberosity intact, but you still have to do holes here in order to pass the sutures from the great tuberosity to the head. Same to the 2-part fracture, but still we need these holes to pass the sutures there. So the rehabilitation, we use only a simple hacking sling for 6 weeks, and then for the first 3 weeks, there is only pendulum exercises and passive forward elevation in the supine position only. After the 3rd week, up to 6 weeks, full range of motion again in supine position, and we start a little bit active exercises. And after the 10th week, we start active range of motion and strengthening. So far, we have a 25 years experience with 265 patients, more than 15 years of follow-up. The mean age of the patient is 54 years, and most of the fractures are valgus impacted in 3-part fractures. All fractures were united except 3. This is, I have an example of non-union, and the mean Scotia score is 86 points. This is a case of non-union. It's very rare in humerus, but this is a 2-part surgical neck fracture, and it's not good indication because it's very difficult to control the big head of the big fragment head with a small diameter diaphysis. It's difficult to put sutures here. I think the best indication in this type of fracture is either a plate or a nail. And this is a case of avascular necrosis. This was an extended indication of a 4-part fracture dislocation, but it was a young, I think 28 years old male. So we revised that to hemiarthroplasty. The rate of avascular necrosis was only 7%. So in conclusion, we can say that it's an easy and reproducible technique of low cost with less soft tissue damage, no need for hardware, allows for early passive motion with a low rate of malunion and avascular necrosis. And of course, there is a possibility for arthroscopic stitched fixation. Now we are doing that for the great tuberosity fractures and some of the simplest fractures. So we perform an arthroscopic technique. Thank you very much.
Thank you very much. Thank you very much, Dr. Andreas. You have a very nice country and a very nice house.
Thank you very much.
Visit Greece one day. Thank you very much for this very elegant presentation. The next presentation will be by Dr. Oliver Verbach under the title Prosthetic Treatment of Proximal Humeral Fractures.
Okay, thank you very much. And again, thank you for the kind invitation. I'll share my screen now. Okay. So I think everybody agrees that in the last decade or so, techniques and designs for prosthesis for the shoulder have evolved quite a bit. But on the other hand as well, I think that many people have changing demands, and especially the elderly, particularly. The time that patients were not treated surgically because of their age has changed a little bit. Just like in this patient who came to see us many years after she was treated conservatively for this fracture dislocation. As you can see, she's quite old, but she still comes to see us and asks us if there's anything we can do about her pain. Not so much the function, but about her pain. I think when you determine the indication for prosthetic replacement or an osteosynthesis or a nail or something else, I think the key question that you have to ask yourself is, what is the bone quality of the humeral head? And if the humeral head looks a little bit like this, like a rotten apple, there's not much chance that you will make it with a fixation, and you'll need to think about a replacement. Of course, that has to do with the vascularity of the humeral head as well, not only the quality, but also the vascularity. And we heard this already before in one of the previous talks. But I must add to that, that the same exact research group showed 1 year later in a follow-up study that actually the immediate peri and postoperative ischemia, what they tested when they made their classification, did actually not predict a necrosis. So the vascularity study is important, but it's not always making a difference clinically. We should keep that in mind. This is an example of a patient that in the end developed a necrosis, but the rest of the fracture healed, the greater tuberosity is in place, and in that time there's still a bailout for an anatomical prosthesis. So I think a vascular necrosis can be a problem. If you're really sure about it, then think about replacements. But again, if it doesn't, if it's not so sure, you can still go for fixation in younger patients. And if there is a necrosis afterwards, there is always a replacement possible. When you make the decision, just like in any other orthopedic problem, I think you have to look at your patient characteristics and age, activity level, general health, control of shoulder function, and patient expectations are the most important when you think about replacement or not. For me, an absolute almost contraindication is the young patient. How bad the fracture, regardless of how bad the fracture looks, I tend to try to avoid a replacement in a young age because they're just too young and too active to support a replacement well. I agree with what Dr. El Safuri showed us, that young patients should be treated with osteosynthesis. You have to push your limits. They usually have adequate bone stock and cuff, and with locking plates and indeed using a graft as a mushroom, you can actually be amazed what the results are, even after a very comminuted fracture. The other part that is important for your decision making, of course, is the pathoanatomy of your fracture. We already talked about bone quality, but also the tuberosities, the glenoids, the cuff, and you should not forget about the deltoid and possible nerve injury when you talk about a replacement. This is a patient that had a reversed arthroplasty for a complex fracture dislocation. And then in the postoperative rehabilitation problem, he was unstable. And the reason was that at the time of the fracture dislocation, the patient suffered from an axillary nerve palsy. This was not diagnosed before the surgery. The surgeon did a reverse and then ended up with an unstable shoulder. An unstable shoulder, an unstable reverse after an axillary palsy is a very difficult thing to treat. So you better know it before you start the surgery. For hemiarthroplasty for fractures, I must say that in my practice, the indication, the window of indication has really become very narrow. I still treat a lot of fractures conservatively. I think about 80% of my fractures. I do prefer plate fixation if I can, and I also treat a lot of them with reverse prosthesis. So an hemiarthroplasty for me has become a really rare thing. Problem with the hemiarthroplasty is that the healing of the tuberosities is the most important part to determine the outcome. And this depends on vascularity and bone quality, and it will determine your functional outcome. The problem with the hemiarthroplasty in my hands is that either it's very good with a good position of the tuberosities, good healing and a good result, or it's very poor, where the greater tuberosity migrates or resorbs, and then you will have poor results. So that's the problem with hemiarthroplasty for fracture. The fixation of the tuberosities can be difficult. They are usually osteoporotic. We tend to over-reduce them and also see secondary cuff problems like cuff tendon rupture or migration of the greater tuberosity. So for me, the best indication still for a hemi is, I would say, in a patient that is above 50-year-olds with an important head split fracture. I think these are past repair and should be replaced with a hemi. It's probably a little bit too young for a reverse still. So in these ones, I try to use a hemiarthroplasty. I think it's not a bad idea to use fluoroscopy during the surgery to get the height of the tuberosity right. Like I said, the tuberosity will dictate the functional outcome, and it's very important. Carlos Torrens has shown already in 2008 that as a sort of a landmark during the surgery, you can use actually the upper border of the pectoralis major tendon, which is about 5.6 centimeter below the top of the humeral head. Some prosthesis systems have used that knowledge to actually use sort of a small measurer to get the height correct, as you can see here. So the prosthesis is reduced, and you use the little measurer to measure the distance of the humeral head from the upper border of the pectoralis major tendon, which I think is a nice tool to have. As you can see, most of the hemis that we do are cemented. Besides the good position of the prosthesis and the fixation of the tuberosities, and the position of the tuberosities, I think you need to have a stable fixation. You need to have a decent suture technique where you try to cerclage the greater tuberosity against the humeral head of the prosthesis, against the shaft of the diaphysis, surround it with the surrounding sutures, do the same thing for the lesser tuberosity, and then also get them all together, sort of construction like this. And we tend to do this in every single case in the same way. In the end, it should look like this, where the prosthesis is completely covered by the soft tissues, greater and lesser tuberosity included. The problem, again, like I said, is that the healing of the tuberosities is still unpredictable. And even if you get a nice result at the time of the surgery, in the end, it can resorb about 20 to 50% following the literature. And that is quite high. This is a patient that I did myself in a case where probably today I would not do a hemi anymore. I would straight go to a reverse. She was 75-year-old. I did a hemi. It looked nice at 6 weeks with a healed tuberosity, greater and lesser tuberosity. But as you can see, at 1 year, complete resorption of that greater tuberosity and a poor function. We had to revise her. This is how that looked during the surgery. As you can see, the whole lesser and greater tuberosity have resorbed. Then it's nice to have a convertible system where you just remove the head and the metaphyseal part. You put on the metaphyseal part of the reverse. You can change the version if it's needed. And it's actually quite an easy revision, keeping the stem in place and revising it to a reverse arthroplasty. This is that same woman again, and as you can see, the left shoulder, she's actually happy now. The only problem that she had was, or the question that she had was, why didn't you do this from the first surgery instead of this hemiarthroplasty in the beginning? And probably she was right asking that. So when do we do reverse for fractures? From day one, if we estimate that the humeral head and the tuberosities are of poor quality, as you can see here, just like in the image, elderly patients above 70 years with poor healing capacity, where you foresee a long rehabilitation with a hemi, we go straight for a reverse. You can see this trends going on in the rest of the world. These are data that come from New Zealand registry already a long time ago, where you can see that the hemi is really becoming less and less common, and the reverse is becoming more and more popular for fractures. The outcomes are good if you compare to hemi. In this study, actually the outcome was about similar, but the revision rate was not different. But at 5 years, the tendency was better for clinical results in the reverse arthroplasty. This again is also a study a little bit older, one of the first studies that was a comparative study between hemi and reverse, and the reverses did much better than the hemis in this study in older patients about 74 years old in average. This, I think, this graph shows you very well the bimodal distribution after a hemi. So you have either very good ones or very bad ones, while the reverse arthroplasty is generally on average quite good. So function of reverse as a whole are better than the hemis. And also you see more complications in hemi than in reverse in this study. So we also treat some particular cases straight away with the reverse. Like in this one, I tend to use a large clinosphere to deal with problems of instability, and I try to fix the tuberosities regardless of using a reverse or not. I think it's important for function, for stability of the shoulder as well. I try to do this through a deltoid split approach. As you can see, this is the front of the shoulder with the lesser tuberosity, and then on the back, the greater tuberosity. I try to fix them, and I leave the superior part open, so I do resect the supraspinatus tendon. This has been shown as well by many others. This is a Chinese or a Korean, I think, study, but also Pascal Boileau has shown this in a multi-center study that healed tuberosities do better, and they improve the functional outcome even after a reverse in terms of external rotation. This is an example of a patient of mine. Of course, this is a very good one. It's not always like this, but she's, as you can see, very happy with this. This is 6 months after a reverse, and even her rotation or internal rotation is actually quite good. So to be clear, it was the right shoulder that we did operation on. I think this type of result you will never get with the hemi, or very, very uncommon. So in summary, for me, I still try to fix a lot of them and avoiding replacement, especially the young ones and the ones that we cannot treat conservatively. I do only about 10% of replacements, hemi replacements, I think. This is only when osteosynthesis has no chance to survive, so a very limited indication. We do now more and more reverse arthroplasties, specifically in the patient that is older, where conservative treatment is not an option. Thank you, and I hope you'll enjoy the rest of the evening, and I hope you can actually join us in the next coming months on our first CESEC virtual congress, and the first edition of that congress is actually next Wednesday with a couple of ICLs and symposia. Thank you very much.
Thank you very much, Dr. Olive. I want to thank you for this very nice presentation. I think there will be a lot of questions. I had the opportunity to attend some of your surgeries in Belgium, and I saw the reverse shoulder and it's very good results. So I wish that there will be a lot of discussions from the audience so that we can know the importance of this reverse shoulder and we can implement in Egypt. The next presentation will be with Dr. Philippe Valenti. He will be talking about tips and tricks for reverse shoulder in complex fractures. Dr. Valenti.
Thank you. Okay. Is it okay for you?
Yeah, it's okay.
It is okay. Okay. Thank you for your kind invitation, and it's a pleasure to do a lecture to my friend from Egypt. And my talk is very technical talk about tips and tricks to implant reverse shoulder arthroplasty. This is my disclosures. It's important to remember that when you do reverse arthroplasty for the fracture, you can restore forward elevation. But if you want to restore external rotation, you have to repair the calf, and you have to repair the infraspinatus and the teres minor, and you have to repair the subscapularis if you want to restore medial rotation. The deltoid is not enough to do external rotation. This is very important. And regarding the supraspinatus, if you can repair, I repair it. Regarding the approach, there is two approaches. The first approach is a superolateral approach. It's very easy because if there is a big displacement of the glad tuberosities in superior and posterior part, if you do a superolateral approach, it's very easy to catch the tuberosities. The problem is the axial nerve, and you have to take care because it's 5 centimeters below the tip of the acromion. When you do a superior lateral approach, you have just in front of you the glenoid, and you can do a very nice exposition of the glenoid. You do a capsulectomy and you dislocate posteriorly and inferiorly the humerus. Sometimes I prefer to use a deltopectoral approach because there is an extension of the fracture to the diaphysis of, if you have a fracture of the diaphysis during the operation, you can extend your approach with a deltopectoral approach. The first point is to identify the tuberosities and to identify the cuff. And it's very important to use a non-absorbable tag suture. I use Masonal endpoints, and I use two sutures for the subscapularis, one for the supraspinatus, one for the infraspinatus, and one for the teres minor. It's very important not to manipulate the bone because many times there is a osteoporotic bone and you have to pass the suture at the junction between the bone and the tendon. The key point for me is not to remove any bone on the humerus. Never. You have to keep the bone. You have to keep the calcar and don't remove the humerus on the glenoid. So we have to implant first the glenosphere on the base plate. You have to respect that. It's clear that if you put too high, it's a bad position. With a superior tilt or neutral tilt is not recommended. The best position is an inferior tilt and in low position to avoid glenoid notch and to obtain a good compression. We prefer to use a lateralization of the prosthesis because if you want to increase the compression of the base plate, you want to restore lateral offset with a good tension of the external rotation, you have to lateralize in the glenosphere and you have to lateralize sometime in the humerus. Distalization is important to increase the strength of the deltoid. And this is the academic rules, and I think that many authors agree with inferior tilt, flush to the inferior border of the glenoid, lateralization and distalization 3-4 centimeters. The first point is how many degrees of retroversion you have to implant the stem. I think that you have to reproduce the anatomy. At the beginning, we implanted with 0 or 10 degrees. Now we try to reproduce the anatomy and we put around 20 degrees of retroversion. And you can use a jig, external jig, to simplify the retroversion, 20 degrees. Regarding the good level of the stem, the good height, I think that if there is a calcar, and the calcar is respected, you can put the stem to the calcar. If you have no calcar, for me, I consider that the inferior part of the stem is at the inferior part of the glenosphere. And with this position, is a good position for the tension of the prosthesis. Sometimes you can use a jig, a special jig, to obtain the good height. You have a good landmark with the pectoralis major, and Olivier talked about Carlos Torrens, 5.6 centimeters. And the most important is after you put the reverse, you have to reduce anatomically the tuberosities and to repair the tuberosities. So you can use many spacer because sometimes the prosthesis is too low, and you can use a humeral spacer of 5 or 10 to obtain a good tension. So regarding the fixation of the cuff and the fixation of the tuberosities, we use a polyester bond at the level of the metaphysis, and we use 4 vertical bands for the suprascapular, supraspinatus, infraspinatus, and teres minor, and we use 2 horizontal bands around the prosthesis. And you see that the pull is opposite to the cuff. So we do it in the same time a tenodesis of the biceps. Regarding the stem, we use cement in the diaphysis, and we use bone graft around the stem to obtain a good heading of the tuberosities. And after, we reduce anatomically the tuberosities vertical and horizontal band to repair the cuff. So the post-operative immobilization is very important. For us, we use a brace during 4 weeks in neutral position, neutral rotation, and 30 degrees of abduction. Never we use a brace in internal rotation because there is a risk of retraction and you lose external rotation. So this is the case. Systematically, we do a CT scan with 3D reconstruction. This is 70 years old, smoker, osteoporotic bone, and we decided to do a reverse arthroplasty. You see that you obtain a good healing of the tuberosities, and this is a result in elevation and external rotation. So with the French Orthopedic Society, with Pascal and David, in 2016, we collected 898 cases of reverse arthroplasty for complex fracture. I show you the result of this series because we have a result with 1 to 5 years follow-up on 420 cases. You see that the range of motion regarding forward elevation is 120 degrees, regarding external rotation is 70 degrees, and regarding of medial rotation is the sacrum. So the absolute score was 57 points, ponderate 86%. More important is the functional result is 70%, and the Adler score regarding the external rotation was 24/30. If you follow the patient after 5 years, you see that there is the same result. We don't lose any forward elevation with a follow-up of 8 years. It's very important to explain for the patient. And there is no fatigability of the deltoid in this case. Complication in this series is 12%. It's a lot. Instability because we did the excision of the tuberosities and enough length of the humerus. Because at the beginning of your experience a long time ago, some surgeon did an excision of the tuberosities, and it's a bad way, and it's a cause of instability of the reverse arthroplasty. 3.5% of humeral loosening is the same problem. If you don't obtain a good healing of the tuberosities, the constraint for the stem is very high, and you have a risk of humeral loosening. Tenoid loosening is a mistake. Infection 1%, and humeral fracture 1%. So if you want to summarize the negative prognostic factor of the reverse arthroplasty in complex fracture is tuberosity excision, bad reduction or malunion or osteolysis of the tuberosities. This is no cuff, it's the bad way, or migration of the great tuberosities. So the good factors, prognostic factors is a patient, a good healthy patient, and the surgery should be good. You have to repair the cuff, you have to repair the tuberosities, you have to obtain anatomic healing of the tuberosities if you want to expect a good external rotation and a good elevation. We prefer to use a specific fracture stem because it's easy to fix the tuberosities and you medullarize the stem. You prefer to use a lateralized reverse prosthesis because you increase the lateral offset, you try to reproduce the anatomy, and we start 4 weeks after the surgery as a physiotherapy, and we prefer to immobilize the patient during 4 weeks in neutral rotation. This is another example, 75 years old, complex fracture. We decided to do a reverse arthroplasty. You see the video of this patient. You obtain a good healing of the tuberosities, and he recovers a good external rotation, good forward elevation. You see that, good external rotation. So the first conclusion is that indication of reverse arthroplasty is 80% of my indication in all patients after 70 years old, when the bone is poor quality, when you have a community tuberculosis and comorbidities. And the better results that we obtain in this big series, is the biggest series on the world, is that if you use a specific humeral stem with lateral center of rotation of the reverse, and if you can obtain anatomical consolidation, healing of the tuberculosis. So the conclusion, if we compare with hemiarthroplasty, is that the results of reverse are more predictable and more consistent than hemiarthroplasty. The message or the key point is the quality of the repair of the tuberculosis if you want to restore extra rotation. So I try to invite you in February, maybe. I try not to be virtual, but I am optimistic, and I invite you in Paris in February next year. Thank you for your attention.
Thank you very much, Dr. Valenti. This was a very elegant presentation. Maybe all the meetings of our friends we can put in our website of the EGSSA, and wish that the Corona COVID passes away, then we can come to Paris and attend this meeting. We hope so. The next presentation.
Thank you, my friend.
You're welcome anytime. The next presentation will be Dr. Samah Ansara from UK. We'll be talking about prosthetic role of PSI in prosthetic treatment of full-part proximal humerus fractures.
Can everybody hear me and see me? Okay. I will start by saying good evening, Tikanis, bonsoir, مساء الخير, and in German, how do you say it? Good evening? Right.
In Germany, we say Guten Abend.
Good Abend, okay.
Yes.
The word is very small. Dr. Valenti, I worked with, actually in Institut de la Main in 2008, I think with Dr. Alain Izerin. I used to visit him every Tuesday, and my fellowship was in Georges Pompidou Hôpital avec Professeur Giraud. I also, j'ai travaillé avec Philippe Hardy on Ambroise Paré. For Dr. Andreas, I come from Alexandria, which is definitely a Greek ancient city. And I love the German and the Belgian football, Dr. Verburg and Nicolaides. So I think, and for my fellow Egyptian, I am originally from Egypt, and I've been in England for 25 years. So I am very pleased to be part of this extended colleagues. And then I would like to say hi to the audience. I think everybody's tired at the end of a long day and end of a very interesting discussion. Actually, my talk is a bit of difficult one. Everything has been covered nicely in the proximal humerus fracture. So there will be, I will raise more questions than answers in what I'm going to discuss. It will going to be a bit philosophical, maybe part of it. And I think it is related to where I come from, Egypt. Recently, I started to visit Egypt 3 or 4 times. Then when I met Dr. Basim, but I was not very lucky to meet Dr. Yasser. There are a couple of points. So my speech will be on the use of PSI with fracture. It is not a common practice, and it is very debatable, and it is something could be have a place in some practice, not all over the world, but in some areas, for example, Egypt. So I work there every 3 months. I do some practice. I work with a friend of Dr. Pfleger, Professor Hafiz, they're both interested in the PSI, and I think they have more experience than me, and I think Dr. Flega can answer part of my questions. The second thing in Egypt, which is, or in India, I have a colleague of mine, I have Dr. Ankit, he's my registrar from India, and I think I want him to come and share with us the Indian experience. So in Egypt and in India, again, there are variants in the specialty and the expertise of the surgeon. So for example, where I work here in England, I am the shoulder surgeon, we have an ankle surgeon, we have a hand surgeon, so there is higher expertise. However, in Egypt and in India, Alexandria, where I come from, it's about 8 million population. There are few eminent shoulder surgeons. They cannot cover the population. So I am going to address for the audience, they have to know there is a big variance in the expertise. So this is for the audience. So I think the audience should learn, and then a few tips and tricks of what I'm going to say. For the audience, I want them to know that there is something called evidence-based medicine, which has been beautifully and nicely presented by all my colleagues about the complication risks of the reverse. The proper paper, please, for the junior doctors or for the shoulder surgeon, the young one, and for the trainee and the audience, read papers, read journals. The proper paper is very nicely illustrated. We are waiting for the second paper to see, and there are more trend of how to say, using the reverse more and more than the hemiarthroplasty. The hemiarthroplasty is dying in the Western society. So the question is why I am going to talk about it. The second point, Dr. Flega, Professor Hafiz, and myself, we try to explore the use of PSI that have used before and to expand it in the use of the fracture. Can you learn a bit more about fractures? Can you have plan for your surgery? I am going to show you a video and a picture to show how when I use the PSI has helped me to do a better exposure and fixation of my fracture. So I'm going to show you the video, then I will see the picture. So this is a CT scan of a patient with a 4-part fragment. Professor Hafiz has the facility to make a plastic specimen. So before going to surgery, I literally lived the surgery, rehearsed it before I go in. I knew whether the greater tuberosity, whether lesser tuberosity. Then I planned for my surgery. One of the difficulties that faces working in different places, in Egypt, in India, then you go to surgery, you don't have all the sizes and all the components. So by doing an PSI, I can measure the height of the prosthesis, where I want to put it. I can measure the size of the prosthesis. So I can have actually a virtual surgery before I go in. There is another thing, it will show me the posterior tuberosity, where it is the greater tuberosity. Once I know the greater tuberosity, I will not miss it. When I started doing my hemis, I used to miss it. So I'm going to show you now one of my recent ones. Can you please show me what I've done it in Egypt? No, the wiring, yeah. I use a prosthesis similar that Dr. Verbroge used. This prosthesis is a cemented stem here, and the top is sprayed with hydroxyapatite, so it allows the greater and the lesser tuberosity to link in, and they use a ceramic head. So you can see here, by doing a PSI, I knew where is the lesser tuberosity is. It's a big chunk, so I got it all. I knew where is the greater tuberosity is, and I do an extra step. I do cable wire through the prosthesis and through the tuberosities. This you can see that there is a good healing of the tuberosities. It allows early mobility, and it allows strong fixation. I don't have to wait for 3 or 4 weeks before the fracture heals. So the PSI has helped me in some sort of fixation to be aware of what I do, and then this helped me with the achievement better result. However, I have to be honest, not all my results are so good. I hid the bad ones and I showed the good ones. So the PSI, it has a place up till now. So do you want to go back again? The second thing I would like to discuss, in England and most of the rich countries, it is not a problem at all to use a reverse. The price and the fees for the surgery is within availability. My registrar will give you a bit of hint about what is the salary of a nurse in India and what costs of the reverse on the prosthesis in India. So if you can let us tell it, please.
So, hello there. Hi,
Yeah. This is Dr. Ankit. He's my. So I want you to give you how India looks like, how Egypt looks like, what is the PSI, what is the Hemi. So at least my talk will have some relevance. Go on.
So in a place like India, the salary of an average nurse the salary of an average nurse is around 50,000 rupees or 500 pounds a month. And the cost of a reverse shoulder arthroplasty is around 200,000 rupees or 2,000 pounds a month. For
So
every
how many months salary?
So that would mean a nurse would have to give in 4 months of a salary for
to have a reverse
arthroplasty.
Thank you very much. The same thing in Egypt. The salary of a nurse, say it's 5,000 pounds, and the reverse will cost 88,000 pounds. So it can tell you now, in spite of, this is for the young doctors and for the trainee, in spite of the evidence-based medicine says use a reverse arthroplasty, we have a problem in these countries. We cannot afford, the NHS in Egypt cannot afford to pay. So this is my question now I am raising. What do we do? Do we look back at the evidence-based medicine, shake it a bit, marry the evidence-based medicine to the socioeconomic status? That's what comes the word GIRFT. I will show it to you for the, this is it. Can anybody see it? GIRFT. It's a concept now I want all the trainees and all the young doctors to know. Get it right first time. So now in underdeveloped country where we don't have enough money, when you don't afford for it, you have to use the cheaper option, the hemiarthroplasty. So my message is, if you can use PSI, if you can use cerclage, if you can use hydroxyapatite, do whatever you can to achieve a good hemiarthroplasty in the underdeveloped country that suit the patient pocket. So I will end my talk by raising question. Can the PSI has a place for the hemiarthroplasty in spite of the evidence medicine is? And if yes, it's a good thing to start to think about it. If no, what to do with the mainstream of patients that cannot afford for the reverse. So I would like to raise more questions than answers, but I give you my very limited experience. It is debatable and it is not a based evidence. Actually, it is going away from the evidence-based. Philosophical question for the audience. I would like to hear from the trainee, the students, and for my colleagues. Thank you very much. I hope I did not give you a headache, but I raised questions more than answers.
Thank you very much. Thank you very much, Dr. Sema. You know, my pleasure to meet you when you come back. So
yes, definitely, yeah.
Dr. Bassem, inshallah. So the next presentation will be by Dr. Bassem Flega, the president of the Egyptian EGSSA, Egyptian Society of Shoulder Surgery. Dr. Bassem will be talking about arthroscopic reduction and transosseous suture fixation of 2- and 3-part fractures of the proximal humerus. Please, Dr. Bassem.
Thank you very much, Dr. Yasser. I'm very happy to make this presentation in Egypt, as I'm now most of the time after more than 30 years working as a shoulder surgeon in Germany. The majority of proximal humeral fractures are non-displaced and need conservative treatment. Displaced 2 and 3 parts fractures are not uncommon and needs intervention. So what's the treatment options? Conservative treatment of the displaced fracture usually leads to stiffness of the shoulder. Percutaneous fixation is not successful in case of osteoporosis or bone comminution, and it is an unstable reduction. Open reduction and internal fixation with hardware is contraindicated in osteoporosis, which is present in 65% of the cases. It has a high morbidity in all patients who build about 60% of the cases and has high risk of avascular necrosis. In 2009, Diamakopoulos group published, as we said so before, the technique of open transosseous suture fixation of proximal humeral fractures. This inspired us to develop an arthroscopic technique of reconstruction. In 2011, we started using a new technique of arthroscopic reduction and transosseous suture fixation of proximal humeral fractures. Before the surgery, an assessment of the fracture is done using 3D CAT scan. Since 2 years, a PSI model is made for every fractured humerus to make a preoperative planning and for intraoperative orientation. The instruments used are the giant needle, the penetrating suture wire, and the chop needle suture puller. The patient is a sitting position with the arm hanging. The portals used are 2 anterior and 2 posterior. The picture is...
the screen is not, we're not sharing the screen.
Yeah. Okay, sorry for that.
Okay, so we're not sharing the screen from the beginning of the presentation. If you want to...
You have the screen now?
Okay. Now it's okay. Go ahead.
Okay, reduction and K-wire fixation is done under imager by reducing greater tuberosity, usually with a hook, and the valgus head with a spatula. In case of varus head angulation, reduction is done by abduction and K-wire fixation. The 4 techniques of transosseous suture fixation used are the vertical giant needle and the horizontal wire fixation technique for the greater tuberosity, the matrix suture fixation of both tuberosities, and the vertical penetrating suture wire for the head and shaft fixation. The reduction and vertical giant needle suture fixation of the greater tuberosity is done by fixing the tuberosity with K-wires, followed by passing the giant needle with sutures through the head medial to the fracture line and tying the fragments with a sliding compression nodes.
This is a greater tuberosity fracture with about 8 millimeters upwards displacement. The line of fracture is passing between the greater tuberosity and the cartilaginous head. After reposition and fixation of the fracture with K-wires, the giant needle is passed through the skin anterior to the acromion, through the supraspinatus tendon, then through the head about 1 centimeter medial to the fracture line, placing an absorbable suture around the fracture. The chop needle puller is passed through the instrumentation portal, then through the supraspinatus tendon immediately above its insertion to the greater tuberosity to pull the suture from its entrance to the head out through the portal, while the lower end of the suture is pulled out at its exit from the shaft with a hook. The two ends are tied outside the joint and pushed as a sliding node to fix the fracture. After fixation of the fracture, the K-wires are removed. Usually, 2 sutures are used for the fixation.
The horizontal greater tuberosity fixation is done by passing a wire with sutures through the head and tying the fractured fragment.
An arthroscopic pointed hook is passed through in the subacromial space to reduce the tuberosity with the arm in external rotation. Then the tuberosity is fixed with 2 K-wires. The suture wire is passed through the head medial to the fracture using a guide. 2 non-absorbable sutures are placed in the distal wire hole. The wire is then pulled out, leaving the sutures through the head. The posterior suture end is pulled with a ring forceps through the portal. The 2 ends of the other suture are rolled with a clamp. The anterior end of the suture is pulled out from the anterior lateral portal. A sliding one-way self-locking giant node is made and driven with a node driver inside the joint. Using the concave node driver, the node is placed in the place wanted to fix the fracture. The wires are then removed and the other suture is tied for more fixation. The fixation is now secured with 2 sutures.
The mattress transtendinous giant needle suture fixation is used to fix the tuberosities to each other by placing sutures in the infraspinatus and supraspinatus tendons and tying them with a sliding compression node.
First, the giant needle is passed through the lateral end of the subscapularis. Then another giant needle is passed through the lateral end of the infraspinatus. The suture ends are pulled together through the lateral portal, and the lower ends are tied together so that by pulling one upper end upwards, the node passes the tendon and can be cut to get a knotless suture through both tendons. Then a sliding node is driven inside the joint to have a mattress suture fixing both tuberosities together.
The vertical penetrating suture wire fixation of the head to the shaft is done by replacing the K wires fixing the head to the shaft with penetrating suture wires. Then by pulling the sutures from the joint and the shaft, the 2 fragments are tied together. Here we see on the left side a K wire passing through the head, and on the right side a penetrating suture wire. Using an Arthrex sharpening forceps, the suture is pulled away from the wire to allow the chop needle puller to pull it out. Is puller immediately above the supraspinatus insertion and pulling the suture out and tying the suture to fix the 2 fragments together. Here inside the joint, we see the absorbable suture compressing the head down. In good, the three parts proximal humor fracture fixation after reduction can be done with the horizontal, the mattress, and the PS wire vertical fixation technique. In case we have a good reducible four parts fractures, the tuberosis can be fixed together with mattress suture. Then the head and the tuberosities to the shaft with PS vertical sutures. This is the X-rays of a case with displaced three parts fracture before and after arthroscopic transosseous reconstruction. The patient 3 months after surgery. Here is a preoperative X-ray of a case of three parts fracture with the head in valgus posterior displacement, completely preventing external rotation, and a post-operative X-ray after arthroscopic reconstruction. Is the patient 6 weeks after surgery. My treatment of choice is arthroscopic reduction and transosseous suture fixation for 2 to 3 parts, and in some cases 4 parts fracture. Between 2011 and 2017, we did 33 cases. 28 patients were examined with an average follow-up of 2.5 years. The average age was 60 years and 70% were females. 21% of the cases were 2 parts, 54 3 parts, and 25% 4 parts fracture. Osteoporosis was present in 62% of the cases, and some had cuff tear. 13 cases had giant needle vertical suture repair, 3 penetrating suture wire vertical repair, and 12 cases a combined repair. Clinical and radiological evaluation was done for all cases. According to NEAR classification, excellent results were found in all 2 parts fracture, in 53% of the 3 parts fracture, and 29% of the 4 part fractures. Satisfactory results were in half of the 3 and 4 parts fractures, and unsatisfactory result was in about 1/3 of the 4 parts fractures. There was no complication of AVN or non-union. In conclusion, the clinical and radiological results strongly encourage to do the arthroscopic reconstruction. There is no disturbance of blood supply. Age and osteoporosis is not a contraindication. The patient can go home on the same day or the second day. There is no complication of osteonecrosis or non-union. It has a minimum morbidity. Thank you very much.
Thank you very much, Dr. Bassem, for this very elegant presentation. There's a lot of questions for the different presentations, which we will discuss. But after this 10-minute presentation of our sponsor, of the sponsor of this webinar, which is Eva Farm. It's our pleasure to welcome Dr. Yunan Al-Khanagri. He is the International Market and Business Development Director of Eva Farm. He will be talking about the role to address patients' needs. Are you here, Dr. Yunan?
Yes. Good evening, everybody.
Good evening.
I'm sorry, Professor Yunan. I'm Abdelaziz from COB. There are 2
Sorry?
Repeat again, please, Abdelaziz.
Yes.
Dr. Yunan, are you here with us?
Yeah, I am with you. Do you hear me?
Okay, could you begin your presentation? We can hear you, yes.
So can you see my slides? evening. Can you hear me now?
Yes, we can hear you, Doctor.
Okay. It's an honor to be with you in this fabulous scientific evening. My name is Yunana Khanagri. I'm representing Eva Pharma. Eva Pharma is a pharmaceutical company that has its headquarters in Cairo. Our vision is to empower the fight of health and well-being for human rights. To do this, we are trying to save and improve millions of lives through very specific targeting products for a very specific groups of patients. From this perspective, Eva Pharma granted license to manufacture and distribute remedies fair in 127 countries in worldwide. As you know, COVID-19 is something that hits us all. And from our vision that we can help everybody in these tough circumstances, we have been trying to bring this product, saving life products, to everybody in 127 countries from the low-income companies. Besides this, and for moderate cases, we have our own brands of having prepared for the same purpose. Eva Pharma have a rich heritage. We have started our company in 1917 and our first manufacturing facility in 1935 that have been nationalized during the revolution. We started again in 1997, and now Eva Pharma has 5 facilities that they are in 5 countries, besides 2 research centers, one in Cairo and the other in Budapest. Believing in quality, we were keen to have our accreditation from the European Medicine Agency and from Health Canada, and now our products are sold in Europe and in Canada, beside all the GMP needed for all our neighboring countries. This our facility that have the EU approval, and now we are trying to get the FDA, and we believe that we have the FDA approval by the end of next year for our new factory, which is located in a place very near to Cairo. We have established our affiliates in Germany, in Hamburg, in 2017, just to cope with our vision to bring the most recent products and medicine to the region. And this LB facility, affiliates has helped us in licensing for the new technologies and work with the multinational in co-developments of new products for the region. This year, we have succeeded to introduce our first Egyptian products in Germany, and we have now 3 products are sold in Germany, and our first product to be sold in Canada. Egypt, Eva Pharma now is ranked number 2 as a manufacturer in Egypt, and we are existing in more than 42 countries worldwide. Our product portfolio is exceeding 130 products, and for orthopedics, we have a very big portfolio that I believe our orthopedics in Egypt, orthopedists in Egypt and in the neighboring countries knows our products very well. And nowadays, we are working with the novel dosage forms like transdermal patches, dry powder inhalations, monodose eye drops, and oral dissolved films. To ensure quality, we were one of the first companies that they adapted the serialization, where every single pack that we produce has this code that is different than any other pack. Now, it is very easy with a very simple scanner to know if any product of Eva Pharma is authentic or is counterfeited. With this slide, I would like to thank you very much for your kind attention. In fact, I have a longer presentation, but I know that after all these valuable presentations, maybe we are already spend a lot of time with you. Thank you very much, and back to you, Dr. Yasser.
Thank you very much, Dr. Yunan. Maybe you can present one of your big presentations in our next Congress. We are planning to have a big international Congress next year in September. So you are welcome anytime to present your presentation.
It will be our honor to be with you, Dr. Yasser. Thank you very much.
Thank you very much. I have a lot of questions here for all our guest speakers. I have chosen few questions. The first question, and I hope that all the guest speakers can share me in the answering the first question, which is about open reduction internal fixation. One is asking about, is there any sequence during your reduction and fixation of the proximal humerus fractures, especially in full port fractures? So he's asking, are certain steps? Would we reduce first the greater tuberosity, lesser tuberosity, or the shaft? So could you have our guest speakers, if they can share in the answering this question? We can begin with Dr. Valenti. Is there a certain sequence you would like to follow during your fixation?
You talk about the reverse prosthesis or fracture?
No, the first question is about the first presentation about open reduction internal fixation. This question was for me, but I wish to have also your.
And in my experience, in my experience, I don't use transverse fixation, but I prefer to use a nail with a cuff repair. I use a straight nail with 3 screws inside the head, 3 or 4 screws, and with a distal fixation, and I repair the cuff around the humeral head.
Mm-hmm.
And I don't use plate because I think that the rate of complication of the plate is very high, because there is many times you have to remove the screw. And I am agree with Bassem and the surgeon from to think that osteosuture, transfixation, open or arthroscopy, because it's very elegant to do by arthroscopy, is a good way to avoid adherences or complication of the hardware. And I think that is a good way, but it's not so easy to do, because we know that to restore the anatomy of complex fracture is very difficult.
Yeah.
And my question is time demanding. How long time you do to do osteosuture by arthroscopy, Bassem?
Well, when we started doing that, it took us 5 hours. And now
5 hours?
At the beginning, yes. And now it is about 1.5 hours, or 1 to 1.5 hours, depending on the difficulty of the case. But it is not less than 1 hour, 1.5 hours.
Okay, thank you. Dr. Andreas, do you have any comments about?
Congratulations. Because...
Sorry, Dr. Valenti, do you want to comment?
Yes, I think that this is a very elegant technique, but I think that the learning curve is very long, because Bassem has 5 or 10 years of learning curve to do that. And I think that for the audience, I think that the key point in the fracture is to repair the cuff, to repair the cuff, to repair the cuff. It's not a fracture for me. When you have a complex fracture of the humeral head, the problem is not the humeral head, this is a cuff. And you have to reduce anatomically the cuff. Even you use a nail or plate or osteosuture, the most important is the cuff. And for me, this is a key point for the fracture.
Okay, thank you very much. Dr. Andreas, do you have any comments?
I agree with Dr. Valendi about that it's not the fracture, it's the functional restoration of the shoulder. So we use always transdeltoid approach. This is very easy. It's a small window, and rotating the humerus, you can see from the medial and the lateral side. So you can grab the tuberosities first, always. We use Ethibond number 5 sutures, non-absorbable, or fiber wire. So in my practice, first I catch the greater tuberosity with 2 sutures, then the lesser. Try to a little bit elevate the humeral head and to correct the varus. I have the transdeltoid approach. I have the head in front of me, so I can know where is the varus or the valgus malreduction, and if it goes, so I can a little bit elevate to create a little bit space for the tuberosities to go underneath. And then I follow these seconds of suturing in the head, in the diaphysis, and I try to do a cross-manner fixation, like in the arthroscopic technique. A cross-manner fixation because you have a better, stronger fixation. Now, I use this technique in 3-part fractures, 4-part valgus impacted. If I have a fracture of the surgical neck, I prefer plate through transdeltoid approach again, or a nail. I never use a nail in 3-part or 4-part fractures. I'm not very confident with the tuberosities, and you put a very big thing inside the head. So, and I have seen cases with absorption of the tuberosities, and then the screw is going out and produces problems. So I prefer either a plate or a suturing. If I have complex fracture, I prefer in a elderly patient reverse arthroplasty, and nowadays I use hemiarthroplasty very rare.
Okay, thank you very much. Any comments, Dr. Oliver?
Yes, congratulations. I think it was marvelous technique. 5 hours is long, so it's a very courageous thing. But yes, of course, if you can fix it like this, it's much better if you don't have to leave metal. I do also put a lot of osteosutures in before I fix my fracture with the plates in the end. Only in young patients, once in a while, it works for me to do it without a plate. But again, I do it open. I did not invest yet in this arthroscopic technique. So it's wonderful. I really enjoyed the presentation.
Okay, Dr. Oliver, I mean, are there any steps? You say that you put your sutures before you put your plate. So do you fix first the lesser tuberosity or the greater tuberosity, and then you put the plate first, then you assembly it to the shaft? Do you have any sequence of steps which you prefer, especially in 3 or 4-part fractures?
Yes, so I agree with what was said. So the reduction is done by putting the cuff back together. So if you have a 3-part fracture, I use my sutures to put in an osteosynthesis. I try to reduce the fracture to 1 part, basically. So I put sutures between the greater and the lesser tuberosity. I put sutures between the greater tuberosity and the diaphysis. I tie them even sometimes, and then I put my plates.
Very good.
For fixation. And I often use a graft in order to have more internal stability. Bone graft.
Can I have a question?
I do not do osteosynthesis in older patients. I agree with Philippe Valenti. Sorry?
Do you put autograft or allografts?
I think my connection is not so good.
What type of graft do you use? Your grafting technique. Do you hear me? Dr. Oliver? Okay, Dr. Samah, do you have any comments?
I think I use the same. I use suture the tendons to reduce the 2 to 3 part. I want to make the head as 1 segment. And then if I have doubt about the quality of bone, I use autograft. And in very few cases, after I fix the screws and then I can see the screws through the fracture, particularly the lower one, I add artificial bone graft. It works like cement. It keeps the head fixed to the plate, and I can move it early. There is another trick I use. I'm not sure if anybody used it before. Sometimes I find difficult to reduce the head to the shaft, and the head goes to the varus. So I've seen some of the wrist surgeon, they fix the plate of the wrist of the distal end of the collis fracture, and they reduce it to the shaft. So what sometimes I do, I fix my plate on the humor, on the head of the humerus where I want, and very, very gentle pulling the suture and the plate, reduce it to the bone. By this way, I guarantee that my fracture will be a bit on the valgus, more on the varus. But I be very careful not to smash or not to rip through. Does anybody use this technique? I wanted to make sure, is anybody use it, or this is something I'm just seeing from the hand surgeon?
I use it for the wrist, but not for the shoulder yet.
Yeah, so we use the same, you put it distal and yeah, that's what I've seen it, and I did it for a few cases, and luckily it did not cut through. But I'm very, very worried that it will cut through one day. Thank you.
We have a question here for Dr. Valenti about how do you restore the calcar if there's a revision surgery and you don't have that length of calcar. And another question that some do not understand the importance of tuberosity reconstruction in cases of reverse shoulder and you don't have the bone stock. Actually, you don't have any rotator cuff. These are two questions: how to restore the calcar and the significance of restoring the bone of the greater tuberosity in patients who do not have any rotator cuff.
Yes, I think that's a complex fracture. You can do contralateral X-rays to measure the length of the humerus, because sometimes you put too low the stem and you have inferior instability. And I think that the key point is to measure the length of the humerus as described by Lederman and Walsh, because many times you have instability of the reverse arthroplasty because you put too low the stem. This is the first point that I think is very important to restore the length of the humerus to a good tension of the deltoid. It's a reason why I don't remove any bone and I try to put my stem to the calcar. If the calcar is completely destroyed, I prefer to put higher, and after I reduce in this position and I cement my stem. And I think that the main point is to restore the length of the humerus to have a good stability of the reverse arthroplasty. The bone graft for the fracture in valgus with a big impaction, I reduce the head and I maintain the head with a synthetic bone. And I restore the calcar with the synthetic bone to stabilize the head, and after I do osteosynthesis. I think that in some fracture, with big impaction, you have to do a bone graft to maintain a good reduction of the humeral head, because the risk is a varus position of the humeral head or valgus position. If you have a bone graft in a calcar position, you maintain the head and you do reduction of the great and the less tuberosities. I think it's very important, depends on the impaction of the fracture. But many times I use fibular graft. Fibular graft is very good because this is a tricortical bone and you have a good stability of the humeral head. And I think that there are some indications of bone graft for osteosynthesis. I agree with you.
The microphone.
There is a question now for Dr. Oliver. Do you hear us, Dr. Oliver?
Yes.
There's a question for you stating that how do you measure the height? This is the first question. The second question, that you have compared between hemiarthroplasty, which you do not like, and reverse shoulder. You did not compare between hemiarthroplasty and anatomical shoulder.
Okay. Yeah, so first of all, last question, hemi or total anatomical? I think there is no good indication to do a total anatomic for a fracture, okay? There's no way, it doesn't make any sense. Hemis used to be the only thing we had, and since we have reverse arthroplasty, for me, it's a much better option, unless the patient is too young. But in a patient that is too young, I will try to save the bone and do a fixation and not a replacement. If I have to do a replacement and he's too young, I will do a hemi. To get the height correct, I think the study from Carlos Torrens is a very good one. He showed that on average, the superior part of the humeral head is about 5.6 centimeters above the upper border of the pectoralis major tendon. So that's a good trick. If you, even in a reverse, you can use that trick almost. Another thing that I like to use is the calcar, the medial calcar. I do just like Philippe. I try to save the calcar because it gives stability and it's a good reference point. And if you put the prosthesis at the level of the medial calcar, and I don't know if you know Agnes Wallace, a famous older Scottish surgeon, he used to call it the Scottish pinky, right? He used to put his small finger between the calcar and the prosthesis. And this is the exact right height. And even that in reverse can help to find the right height of the prosthesis.
Thank you very much. These are the questions which I have. So we have ended this session. We'll begin the second session, which is about case discussion. I will present a case, and Dr. Bassem Flege will present another case. Okay. So this is a case presentation. Okay. This is a patient. He's an athlete. He's 25 years old. Do you hear me all?
Yes.
Okay. This is a patient, 25 years old. He's an athlete. He was playing judo and had this type of fracture dislocation. He had no neurology, no nerve injury or vascular injuries. So the question now, he presented to the surgeon with this X-ray. Anyone wants to add another type of investigation? We'll begin with Dr. Flege.
I can't see the picture. I can't see any X-ray.
Sorry?
I can't see any X-ray. I only see you. There is no X-ray.
Okay, this is the X-ray. Do you see the X-ray now?
Okay, it's the upper part, yes, okay.
Okay, so this is the X-ray of the patient presented to the surgeon, coming directly from his club with the injury, and he's an athlete. So what is the second step? When you receive this patient, would you do another X-rays? Dr. Bassem? Do you hear us, Dr. Bassem?
Well, if I have this case like this, I will do, of course, a CT scan, a 3D CT scan, and PSI. So I can really cover the whole situation, anterior and posterior, and where is the shaft located to the glenoid or stuck to the glenoid.
Dr. Valenti?
Did I answer your question? No?
Yes, thank you very much. Dr. Valenti?
Yes, I think that my recommendation is to do a scan with 3D reconstruction with to analyze the glenoid. I agree with Bassem to analyze the cuff. The cuff is good, I think. The cuff is very nice because it's a young athlete, it's a young guy. And for me, it's a good indication of osteosynthesis, of course.
We'll do a CT scan, 3D CT scan?
Yes, systematically I do a CT scan to
okay,
Dr. on the cuff and the trophicity of the muscle.
Very good. Dr. Oliver?
Yeah, basically the same thing. I would go for a CT scan just to make sure that I understand the fracture well. 3D reconstruction, yeah.
Dr. Sameh?
I think there are two things here. The head looks like could be dislocated, and it looks like dislocated. So CT scan, I use deltopectoral approach. I know other surgeons, they are familiar with other things, but in my hand, I do quite a lot of abduction, relaxed deltoid, and I think
I will do this type of surgery, but I would begin it as a first step that the patient coming to you, you will have X-rays.
A CT scan.
MRI, for example, or you don't need to do an MRI?
Sorry?
Would you do a CT scan? Would you do an MRI?
No, I don't think MRI here will be necessary. I need to see the condition of the bone, what's going on exactly, and I think it's for fixation.
Okay, this patient presented to the surgeon. He considered it as an emergency. The patient was in agony. He did not have them to do a CT scan, and they depended on the X-ray for surgery. So when we consider this case as an emergency, and we should take the patient direct to the surgery, or it is an elective case, and you have the time to do PSI, or we do other types of investigations. So we'll begin with Dr. Bassem. You consider it an emergency, and you should go to the patient direct.
Well, it depends. It depends. I see the head is anteriorly dislocated, and it may be compressing on the axillary nerve. So I would do a nerve assessment, and if the nerves are all okay, I would not consider it as emergency. Do it one way. So I do my investigation first.
Thank you very much, Dr. Philippe Valenti.
Yes.
Would you consider it an emergency to get the patient directly to the OR, or you will have some time to do your investigation?
Yes, I think that is no, it's an emergency. We have to do operation as soon as possible because the head is dislocated. It's not so good for the nerve, for the brachial plexus, for the axillary artery. I think that when I have a dislocation of the shoulder, even there is no nerve lesion, I prefer to reduce as soon as possible. For me, it's an emergency case.
Thank you very much. Dr. Verboch.
Yeah, sorry, my Zoom connection is very...
Would you consider this case as an emergency case where we should have quick...
yes, absolutely.
You hear me?
Dislocated. So yes, but, so I would do it within the 24 hours if I can, but I think it needs to be a shoulder specialist.
Very good. Dr. Sameh?
I think if there is any neurological or vascular problem, yes. But if this patient come to me at 9 o'clock in the morning, I want to do him before night. I will be comfortable to organize. But if he come around 8, 9 o'clock in the evening without neurological, this is not the operation that I would like to go at 12 o'clock midnight. So neurovascular, yes. No neurovascular, I would like it to do it daytime, comfortable, be ready to deal with any unplanned things, but I don't want to go if there is no neurovascular during this is not something for me during midnight. If it comes late in the evening, he can wait till tomorrow morning if there is no neurovascular.
Okay, thank you very much. Okay, what is the decision? What type of surgery will you going to prefer to do for this patient, Dr. Bassem?
Well, he's a young patient. I would try to do an open reduction and internal fixation, especially if the head is still in a good position. I cannot evaluate it exactly with this X-ray, but if the head is completely damaged, so I will go for prosthesis. And I use the hemi arthroplasty. I would use it for this patient because he seems a young patient.
What approach will you use?
I would do the anterior deltopectoral approach and with the slight resection of the insertion of the deltoid distally.
Thank you very much. Dr. Valenti?
For me, it's not an indication of arthroplasty, never. 25 years old, I always to conserve the human head, and I do anatomic reduction. I don't think that the head is destroyed. I think that the head is correct. The most important is to reduce the calcar, the medial calcar, with a stable reduction of the calcar. If you have a stable reduction of the calcar, you can use a plate or nail as you want with a deltopectoral approach. 25 years old for me is very, very young for hemiarthroplasty. Even there is a necrosis of the humeral head, is not a problem for me. The problem is great tuberosities and less tuberosities and reduction of the fracture. Is the reason why for me osteosynthesis is the main indication for this patient.
Thank you very much. Dr. Andreas?
Yes, I agree with Dr. Valenti. Never arthroplasty in such a young patient. I will use a long plate with a deltopectoral approach. Now, because this is a fracture, a three-part fracture with a metaphyseal extension, you use more stability. So you need 3-4 holes below the spike. And of course, the tuberosity is very comminuted, but you have to restore the supraspinatus, definitely for osteosynthesis. And not in the night, because this is not a good case to do it 3 o'clock in the morning. Okay? If it comes 10 o'clock in the night, I can do it 8 o'clock in the morning with a clean head. Okay, be prepared for everything.
Thank you very much.
Unless if there is a neurovascular injury.
Exactly, yes. Thank you very much. Dr. Verboch?
Yeah, same thing. Definitely go for osteosynthesis, never an hemi in this age. Try to get it anatomically reduced. Deltopectoral approach. Use osteosutures to help in the reduction, and then put. I rather put a plate laterally.
Okay, thank you, Dr. Sameh.
I think my approach is always to look at the patient in general. He's 25. Most likely, you mentioned a judo player and a non-smoker. So this is two good points. Secondly, I will look at the X-ray. According to the Hertel classification, which it gives you some prognosis, the calcar is about 1 to 2 or actually 3 centimeters good. So this is another good sign. The head is medially displaced or rotated. So possibly the CT scan will show you this, but possibly the lesser tuberosity looks like possibly, I'm saying possibly. If it's in one piece with the head, this is another sign that the good vasculatures. So this will give me an idea. The most important thing here, before even surgery, I need to speak to the patient, tell him the prognosis. So the patient is in the same boat with me, then I will go. And in my hand, I use deltopectoral approach, relax the hand in abduction. I have to reach the posterior. And then we can see at the age of 25, most of the dislocation of the shoulders, greater tuberosity fracture, and the tendon, most likely the supraspinatus will be intact. most likely the subscapularis will be intact, good reduction, and I don't think I need to do anything for the dislocation, Bankart or whatever. If I reduce the head, all what I'll do here a bit differently, if my colleagues will agree, I'll put him in a slight internal rotation in the collar and cuff, so the head will not be tended to redislocate.
Thank you very much. This is the post-operative X-ray after a few months, showing healing of the fracture. Any comments for this type of fixation, Dr. Bassem?
Well, it seems a good fixation. The rotator cuff seems to be stable. Maybe the plate is a little bit high. I would do it a little bit lower. But there is also the shaft that is a little bit laterally fixed. But I think it will heal good. So I think it is not bad. Thank you.
Thank you very much. Dr. Valenti?
Yes, I agree with Bassem, a little height. I like what if you do a plate. I think that if you use a screw which is parallel to the medial calcar is very nice, but it's not so easy. But in the plate, there is a good direction, more oblique. You understand, more oblique in the head to have a good support of the medial calcar. I think that the risk of this system is a malunion, a non-union, or a healing after 6 months. For me, I prefer to use a oblique long screw parallel to the medial calcar to support the calcar. But I think it's a very good operation, and congratulations for this, my friend.
Thank you very much. Dr. Andreas?
Yes, I believe that the lower screw in the head will be a little bit more parallel. 2 screws there, going almost in the cartilage. This reduces more stability because this area between these screws, it's a little bit risky for varus malunion at the end. And the plate is a little bit high. I prefer 1 centimeter lower. And I don't know what happens with great velocity. I can't see it with this picture. I need an auxiliary view as well, because it looks like a little comminution there. Did they use bone graft for that?
The greater tuberosity, you think it's displaced?
Not displaced. I think it will be absorbed at the end. It looks from the first X-ray that is a little bit comminuted. So the main thing is to put the tendon in the right place. But sometimes you see that absorption of great velocity even with the plate.
Thank you very much, Dr. Oliver.
Yeah, it's a difficult fracture. I agree with everything that was being said. I'm not so sure about the greater tuberosity on this image, but that could be positional. I agree on the height of the plate. And I also agree on the calcar screw. If you can have one just a little bit more in the calcar, could be better for stability, but otherwise it's going to heal. It's a young guy, so he has good bone and the alignment is good. So.
Oh, very good. Okay, Dr. Samah, do you have any comments?
I think it would be very easy for me to sit on my sofa and then criticize. I would be sweating doing this type of fracture. However, this is at 2 months or more or less or more.
Follow-up X-ray?
Yeah. Is there any later X-ray than this? Because I could see there is some like loosening of the screws or just some shadow around the screws here. So is it 2 months or more than 2 months or less?
More than 3 months or 4 months. This is one of the follow-up X-rays.
I still cannot judge very much the healing. That's what my question is. So I prefer to see if, so is this the final X-ray or there is any more X-ray?
The final X-ray.
So final X-ray. Any lateral view?
Unfortunately, I don't have the lateral view here, but
it is a difficult fracture, as I said. It is easy to, but as long as it's healed, I'm happy.
Okay, because this patient after 6 months had a good or an excellent constant score. He can do all the ranges, but still he had limitation in the overhead elevation. He could not reach 180 degrees compared to the other side. And he is an athlete. Also, he had some anterior shoulder pain. He had some weakness of the deltoid. And he's unable to feel that he is strong enough to go back to his original sports. So my question, in these types of fractures with dislocations, do these patients return completely to their normal life and can go back to their original sports, these fractures, dislocations? What went wrong, and if we can help this patient? Dr. Bassem?
Well, I think that the patient after this surgery can go back to practice his normal life. I think he may have some problem with maximum elevation due to impingement. This may happen or may not. It depends about according to the space between the acromion and the head. I mean, the impingement of the subacromial space. The rotation seems to of the head to the shaft seems to be in the normal position, so I expect him to have a normal rotation, external and internal. So if this is the case, so I think he can go back to his normal life.
Thank you very much. Dr. Philippe? These types of patients in your experience can go back to their original sports?
I think it's very difficult because there is lesion of the capsule, there is lesion of the labrum, there is lesion of the anterior and inferior glenohumeral ligament, and I don't know what is the cuff. The cuff maybe is partial lesion. I don't think that it's possible for this kind of patient to return to his original sport. It's a big trauma. And even you reduce anatomically, there is a risk of complications as adherences, stiff shoulder, or unstable shoulder. Or I don't think that necrosis, because the calcar is very large and the vascularization of the head is good in this case, and it's a young athlete. But I think that many complications are stiff shoulder or anterior pain or subscapularis pain or partial lesion is very common.
Thank you very much. Dr. Andreas?
I agree with Dr. Valenti, because it's a big trauma. It's a fracture dislocation. So you don't know what happens with the capsule, with the labrum, with the biceps, the calf. Have you considered to remove the plate and to give a little bit more motion?
Would you do an MRI to assess the labrum?
It's difficult to perform an MRI with a plate because there is a lot of artifacts. So if the limited range of motion is a problem, then you can consider removal of the plate and to see the capsule or the cuff.
Okay, thank you very much. Dr. Oliver?
It's a very bad fracture for a young guy. If he's at a high level and he sustains that type of fracture, then you can only wish for good recuperation if you can get the fracture as anatomical as possible. And otherwise, it's difficult. At this point, can you do something else? Not so sure. New trauma can also cause new problems. I would definitely need more imaging to see if I could actually do something extra by, for example, removing the plates. So I would do CT scan, see how that looks. But it's not sure that you can win a lot in the second stage.
Thank you very much. Dr. Sameh?
I think I've said during my assessment, one of the main points I do before any surgery, I assess the injury. This guy had the full Monty. He had a fracture, actually comminuted fracture, not a fracture. And he had a dislocation. So this guy, all he needed, the axillary nerve and his shoulder is done. So I consent the patient before I touch him, and I'll give him actually, in our nowadays, a bleak picture. So what I mentioned before, I engage the patient in the, with me. I don't do miracles. So he knows that most likely, he will never get his movement again. Then if we aim for healing, then he will know that before going to surgery, he might not go back to play sports. Now, he has pain. The X-ray I've seen, it is 3 months. I need an X-ray now to check. I have doubt about the union. The second thing, I have seen the X-ray at 3 months, there is some loosening around the screws. So I will need to do full blood count, ESR, CRP, to exclude infection. Either a CT scan or CT scan to check the union. I need one if the X-ray is not conclusive. And then if in doubt or something, an ultrasound to check the rotator cuff. So I need to exclude infection. I need to make sure that this guy has union, and then I will address the deltoid, the rotator cuff or that union. So I will go systematic. But all my patients, I give them literally, shoulder is a nasty joint. And he got fracture, comminuted, and dislocation. So beforehand, I would prepare him.
Thank you very much.
He will not go back to work, most likely, until we see what's going on.
Thank you very much, Dr. Sameh. All of you, of course, are very tired after this long day, but we have a very interesting case now from Dr. Bassem Flega, and then we will going to end our webinar by a very short presentation from our sponsor company at the end of this day. And there will
be any dinner or anything?
Sorry?
And are you throwing any dinner for us or anything at the end or not?
There will be an announcement about our future plans.
Okay.
So now Dr. Flega will present his case.
First, I want just to make
please share your screen, please.
Yes. Till this I just want to say to Philip, I agree with him very much about the importance of the rotator cuff in treatment of the fractures. It is very important that also by doing the arthroscopic reconstruction, we first fix the shaft to the head after reducing the head. And then with a mattress suture, we pull the two tuberosities together in neutral rotation of the arm, so that the tuberosities with the tendons, with the subscapularis and the infraspinatus, they will pull the two fragments together, and it is automatically will push the head to its position. So this is a very important step in the treatment. Also about the time, we started doing this surgery, this is as Oliver said, we started doing this surgery with 5 hours, but with the time, in 3 years, we improved the technique, so it took us about 2 hours or 2.5 hours. And then with using the PSI, we reduced also the time very much, because we can plan the surgery before doing it, and this helped us very much, so that the time now is about 1.5 hours. We have a problem here with having the
Screen?
The screen, yes.
Okay, so you want to cancel it or continue?
Do you have a website? We can present it on the website, and we can, if you cannot put it, and we can all reply to it.
Also, we are late in time.
Yeah.
Okay. Maybe you can just thank
Dr. Yasser, I suggest put it on the website to each of us, and then we can reply with a simple 10-line. Yeah.
Okay. So, Dr. Yasser, you can finish the webinar now, and I have an announcement to do after that.
First of all, I want to thank our guest speakers. We are very, very delighted that you joined us in our first webinar. We are very proud that you have accepted our invitation and participated in this first webinar. We have a lot of future plans. We wish that we can organize an international meeting next September and invite all our friends and all the societies. Dr. Bassem Fliega is very eager to make this happen, and he's the godfather of shoulder surgery in Egypt. So I pass to him the last sentence or talk about this webinar. Dr. Bassem.
Thank you very much, Dr. Yasser. Also, it is my honor and great pleasure to have Andreas, Philip, Oliver, and Sameh with us. And I hope very much that we have you in the future. And also, I would like to go to Paris and Belgium. I have my sister living there since 40 years, my only sister. She works at the UNESCO in Paris. So actually, I think this will start of a good relationship.
Dr. Valenti will join us in the elbow webinar. Dr. Valenti is a very good elbow person also. He's going to join us in the elbow webinar.
Thank you very much.
Professor Yasser, we still have another presentation for EBA with Dr. Mina.
Exactly.
Yes, I just want to announce that our next webinar in October will be on the brachial plexus injuries and in Earth's palsy. It will also be visited by many world experts in this field. And I want to also announce that the certifications of participation in this webinar will be sent to all participants in 3 days per email. Also, with the certification, there is a survey about this webinar, and we will be very happy to have you send us your response to the survey, because it helps us very much to improve our performance in the future. Thank you very much all, and I wish you a good night.
Dr.
Now,
Yasser,
I thank also Eva Farna, because they helped us in this webinar, and I would like to give them the talk to present their presentation now. Thank you.
Thank you very much, Dr. Bassem. As regards the coming webinar in October, will be on shoulder problems in erg palsy and reconstruction. One of our aims in the Shoulder Society is to tackle all the problems of the shoulder, beginning from reconstruction, neuropathies, arthroscopy, microsurgery, all the problems which happen in the shoulder, and a lot of surgeons need like different protocols to treat these types of patients. So our Shoulder Society covers open and arthroscopic surgeries. Thank you very much. Now we're going to present Dr. Mina Munir from Eva Farm, which we want to thank. We will be presenting compressive neuropathy management approach. He's the product manager of this product in Egypt. Thank you very much. Thank you, guest speakers. Thank you very much.
And we say, merci beaucoup, dankeschön, ya khara, shukran. And thank you very much. Enjoyable.
Dr. Mina, do you hear us?
Thank you, Bassem.
Yes,
Thank you,
yes,
Yasser,
Professor Yasser, I'm with you.
Okay, you can go ahead. Thank you, all guest speakers. Thank you very much.
Dr.
Okay,
Yasser, just one more thing. I have to include my registrar for the certificate. He's been with me since the meeting, okay?
Okay, no problem.
Thank you very much.
Congratulations to Dr. Best.
Yeah, thank you.
Thank you very much, all of you. Thank you very much.
Thank
Dr. Mina?
So first of all, I would like to thank you, Dr. Yasser, and the first webinar of the Egyptian Shoulder Surgery Association. It is our honor in Eva Pharma to be with you this night. And I think that most of the presentations by the eminent guest speakers were talking about shoulder, and for sure, many patients who are suffering from shoulder disorder are suffering from some sort of neuropathy due to nerve entrapment. So it is my pleasure to share with you some important point about one of the most products in Eva Pharma, which is Cytacid, which is addressing peripheral neuropathy. And according to the International Association for the Study of Pain, I'm sure that you agree with me, in order to treat neuropathic pain, which is one of the most annoying pain that the patient might suffer from, is first of all to treat the underlying cause. Maybe it not be possible for all patients to treat this cause, also the symptoms of painful neuropathy, and at the end, what is behind the neuropathy and the neuropathic pain, which is the nerve fiber damage. And here is what I'm going to talk with you, is the nerve injury. And for sure, as you see, the cascade of nerve injury that's starting from compression, going through all the pathophysiology of neuropathy, ending with degeneration whenever the cause is not treated well. But in order to agree with you what is the pathophysiology of entrapment in neuropathy, these underlying the three causes or the three pathophysiologies under these three titles, starting from microvascular changes, injury and demyelination, and for sure inflammation, inflammatory mediator generation, and oxidative stress. Here is what causes the nerve to express its pathophysiological or maybe the pathological effect it's suffering from in the form of neuropathic pain. Here comes the role of Cytacid, and I do believe that many of the doctors here in our webinar this night know Cytacid, or in other words, its active constituent, which is alpha lipoic acid or thioctic acid, by its powerful combined actions for treatment of neuropathy that I will discuss shortly with you. But first of all, what is Cytacid? As I said, it is alpha lipoic acid or thioctic acid. In many papers, it is mentioned thioctic acid. It is sensitized in the liver, and all individuals are having alpha lipoic acid inside their cell because it is a coenzyme in Krebs cycle important for energy production. Alpha lipoic acid has some characters that is affecting its action along the body. Alpha lipoic acid is a water soluble and fat soluble because by this way it can reach inside and outside the cell. Alpha lipoic acid acts but both reduced and oxidized form, so it has extended action. What is the mechanism of action of Cytacid? It is vasoprotective action, neuroprotective action, and antioxidant action. starting from the vasoprotective, it works on improving the blood supply, especially in the vasonervorum, which is the minute blood supply feeding the nerves. It restores the nitric oxide level, and being a potent antioxidant, it prevents the adhesion of some toxic metabolite, and especially for diabetic, advanced glycated end product to the endothelial cells, and acts as anti-inflammatory by inhibition of activation of nuclear factor kappa B and also the tumor necrotic factors. The other action of thiacid, which is neuroprotective action, by regenerating the damaged nerve fiber, and at the end, it increases or enhances the nerve conduction velocity and increases the nerve growth factor, which is an important factor for sprouting the nerves. And as I said before, alpha-lipoic acid is a cofactor in Krebs cycle, so it increases energy production through its roles in the Krebs cycle. And it is known also, thiacid or alpha-lipoic acid, as a universal antioxidant by its very strong, potent free radical scavenger and metal chelator as well. Also, it is not also an individual antioxidant by itself, but also it boosts the action of other antioxidants like vitamin E and vitamin C extracellularly, or the intracellular glutathione inside the body. Thiacid or alpha-lipoic acid have protective actions that I have mentioned shortly that acts on nerve inflammation and disease progression. Do you remember with me that we have agreed on this pathophysiology of nerve entrapment or nerve compression syndrome by discussing the action of thiacid? It has vasoprotective action addressing the microvascular chains. It has neuroprotective action addressing the injury and demyelination, and by its antioxidant effects and anti-inflammatory effect, it is addressing inflammation and oxidative stress. A lot of evidence-based medicine focusing on the role of alpha-lipoic acid or thiacid, but due to time restriction, I think we have no time anymore. Many papers, maybe in the next webinars, we might discuss in details these papers illustrating the role of alpha-lipoic acid in maybe chronic neck pain, in sciatic neuropathy, and in carpal tunnel, and in general in peripheral nerve injuries, other than for sure the diabetic neuropathy. So indications of thiacid may include diabetic neuropathy, all entrapments neuropathy, including carpal tunnel, low back pain with sciatica, maybe even for neurological doctors, they might use these neurotropic agents in some nerve demyelination disease like trigeminal neuralgia or facial palsy as well. So for a drug to be effective, it is great, but what about its safety profile? Because I'm sure it is a very important point that many medicines have been very effective, but it has been withdrawn from the market due to its safety concern. Alpha-lipoic acid has been discovered in 1958 in Germany and has been approved for treatment of diabetic neuropathy. I do believe that it has been over 60 years used without any concern on its safety. So up to we don't need those adjustments with elderly patient using thiacid, renally impaired patient with its different stages, even the end stage renal failure, for patients suffering from liver disorders, and also cardiac, hypertensive, and diabetic patients. So effective molecule in thiacid with high safety profile ensure giving the patient a chance for treating the neuropathy. Regarding the dose, recommended oral therapeutic dose of alpha-lipoic acid range from 600 to 1,800 milligram daily. These range differ according to the severity. So it is recommended that start with high dose, then gradually increase the dose as a maintenance dose. A very important note for this molecule specifically is to give this drug, thiacid, on an empty stomach. Whenever the patient have no meals in his or her stomach, so maybe before meal by 30 or 60 minutes, or after meals by 2 hours. This is to ensure maximum absorption of this molecule, which need very low pH in the stomach. So we can start for 2 tablets or maybe 100 milligram for mild and moderate cases, and 800 milligram for severe cases for a specific period of time. Then we might decrease the dose to its maintenance dose as once daily of the 600 milligram dosage form. Also in Eva Pharma, we are having, as Dr. Yanan mentioned, a portfolio of drugs or medicines for orthopedics. We have Sympatix, maybe registered in some countries as duloxetine and conventine as gabapentin for neuropathic pain, as neuropathic pain modulators or passive painkillers. Also, we have Genovil and methyl sulfonyl methane members in our strong portfolio for orthopedics. By this, I have come to the end of my presentation. But before ending my presentation, indeed, I would like to congratulate you all for the launching webinar of the Egyptian Shoulder Surgery Association. I would like to thank Dr. Bassem being the president of the EGSSA. Also, Dr. Yasser Safouri, thank you very much for this chance being with you this night. Also, I would like to thank all guest speakers. Indeed, it was a very valuable webinar with rich presentation and rich discussion. Dr. Valenti, Dr. Andreas, Dr. Oliver, for sure, Dr. Sameh and Dr. Nicola. Also, Dr. Sameh, you are specially invited and all the attendees to have dinner here in Egypt on the bank of the Nile at any time. So thank you very much. And I do believe that you have a good night. Thank you. Thank you.
Thank you, Dr. Mina. Thank you very much for your sponsorship. And we hope that you can help us during our predetermined program of webinars until the Congress, so that
sure,
we'll have
Doctor.
a good event and an international strong event. Thank you very much.
Sure. Thank you.
Anything, Dr. Fliega?
I want to especially also thank the audience and thank all the participants and the experts and the Eva Pharma for all their engagement in making this webinar a successful event. Thank you very much.
Thank you very much. By this, we have ended our webinar meeting. Thank you very much. Thank you very much.